Today I talked about headaches in hospitalized patients in the broad sense. And what I wanted to emphasize to the learners is that headache is actually a really common problem. And when it comes up in the outpatient setting, it's usually a primary disorder unto itself. But in the urgent or inpatient setting, there's a greater risk for secondary causes to the presentation, but it could also be that this individual has something like migraine and it's become exacerbated by whatever's going on with them medically. And so knowing what some of those common destabilizers of migraine disease are is very important, as well as knowing what some of the more serious secondary causes which require immediate attention are. A new headache in a hospitalized patient isn't always brand new. It might be the newest form of headache for that patient. It might be the worst headache that they've experienced, which is why it's important to really assess, is this brand new? Has this patient never ever had a headache before in their lives? Or are they somebody who has experienced headaches on a recurrent basis for years to decades, and now they're having a really bad exacerbation? This is where history is so critical. I really like to hammer home how important taking a good and thorough history is. You have to first, in the back of your mind, know what could lead to headaches, what can cause headaches. So does this individual have a primary headache problem like migraine? Or is there something going on which has now affected the pain-sensitive intracranial and extracranial structures that actually generate pain? Or is there a little bit of both? Somebody with migraine could have a problem with their blood vessels, for example, or a problem with their sinuses or an infection, and that's going to amplify their pre-existing headache problem. And it can also cause a brand new headache problem for somebody who's never had it before. Somebody who's never had headache before, you really need to worry, especially in the acute setting. But somebody who's been prone to headaches, you want to manage two things at once. You want to make sure you're identifying what has led to that exacerbation and manage it, but you also have to be able to manage the underlying disease effectively. It all starts with history, always, always, always. Try to get a thorough understanding, not just of the acute presentation and what symptoms the patient is experiencing besides headache, such as light or sound sensitivity, nausea or vomiting, neck pain, fever, other systemic symptoms. This really helps you to differentiate, all right, how much of this problem is a total secondary cause? How much of this problem is exacerbation of a primary or pre-existing headache? And how much might it actually be blended? That's really where you need to start. You don't want to be jumping right to doing testing, except in the hyperacute scenario, say, trauma, coma, okay, we need to get a CT scan or something like that right away. But when you've got the time to take a history, the history is what guides us, because diagnostic testing results out of the context of a history also don't really help you. And a non-orderly, non-systematic approach to diagnostic testing wastes time and resources. So you really need to have that history and your exam backing up your decision-making when you're going down that diagnostic pathway. We also need to consider that it's not always medications that can make a headache problem better. Sure, there are plenty of symptomatic approaches to treating head pain, nausea, and some of the other associated symptoms. And I outlined them in exquisite detail in the talk. But you also have to consider other factors which are not related to utilizing medical therapy or might be a consequence of medical therapy that led to that headache. So take away medications that might be triggers or exacerbants for a headache, particularly opioids. That's a big time medication that can activate or aggravate, especially underlying migraine. Also consider what's going on in the hospital. Getting good sleep is not easy in the hospital, and that disrupted sleep-wake cycle will activate or exacerbate migraine. Caffeine withdrawal is another big problem. We're not usually wanting to give our patients in the hospital large amounts of coffee first thing in the morning. If that's what they're accustomed to doing every day and suddenly they can't, you're going to get caffeine withdrawal headaches. Positioning. if they've been in the hospital for quite a long time on prolonged bed rest, this can lead to compression of the occipital nerves. This can lead to musculoskeletal pain from being in an awkward position or just being bedbound for a long time. So paying attention to physical modalities and enlisting good physical therapy practices is also important to help mitigate and even prevent headaches in many circumstances. Headache is something that a lot of clinicians fear when they hear it from their patients. They're worried that something very scary is going on that they're going to miss, and they don't want to miss it, and they want to make sure that they're getting at it fast. And they're inclined to just phone a friend and call a specialist. But I want all clinicians to feel empowered to be able to assess this very, very common problem. Headache is almost ubiquitous, and particularly migraine, the most common of primary headaches, which comes to medical attention. It's present in 12% of the population broadly, and up to a quarter of women of reproductive age. So you really need to be on the lookout for it and not shying away from it, because the initial approach in management is actually pretty simple. And when you can help these patients there and in the moment, it's very gratifying for the both of you.